cell-free DNA screening. I want to talk about that first because it's being done a lot more. And people often think that it's diagnostic. It is not diagnostic. It is still a screening test, although it performs better for certain chromosomal differences than, like, say, the quad screen, and we'll talk about that. It is still a screening test. So definitive decisions about a pregnancy, one way or the other, should not be made based on a cell-free DNA screening test.
Yes,
it is still a screening test. So talk about the cell-free DNA screening test. Like, what exactly is it? How is the test done? Where are they getting that? It used to be called cell-free fetal DNA, but NIPT is Panorama. Some of the other tests, there's so many different names, but they basically they're all cell-free DNA from the fetus. How do they do that test?
So
like,
it's a blood test, so it's not a risk to the pregnancy at all to do that kind of testing. And it's used to be called cell-free fetal DNA, but it's not actually directly from the fetus itself. Our interface with the pregnancy is actually through that placenta, and cells at the edge of the placenta that then go into our uterus and then through our own bloodstream are shedding off from there. So that DNA that's broken up in the blood that we get from the pregnancy is actually stemming from the placenta. So normally we all have free-flowing genetic information, little bits of chromosomes floating in all of our blood. And when someone's pregnant, they're going to have a little bit of that as well coming from the placenta. It's what they calculate as the fetal fraction, or the amount that they consider to be coming from the pregnancy itself. And so able to measure that to see how much they'd expect to see from you in pregnancy at that point in pregnancy, and how much they're actually seeing. And if there's a difference there, it's pretty unlikely to be coming from the patient themselves. And so that increases the chance that there's a difference coming from the placenta, and therefore increases the chance that there's a difference within the baby. And that's how they screen for some of the more common chromosome differences that can continue through pregnancy and have babies be born with those conditions.
Yeah, someone had asked me before on another topic, how is it that if the fetal DNA or now we know it's not actually from the body of the fetus, it's from the actually trophoblast layer of the placenta is where that DNA comes from and enters the maternal circulation. How are the pregnant individuals not recognizing it as foreign and launching an attack? Like when we think about, say, red blood cell alloimmunization or Rh negative situations. It's different because with Rh negative, you're getting a whole red blood cell exchange with the antigens on the actual surface of the red blood cell that the maternal circulation gets access to for whatever reason. And then that's when the antibodies are formed against those fetal antigens on those red blood cells. So it's not just DNA circulating. That's a totally different, pathophysiology of the disease process with like Rh disease than with what we're talking about here. So the maternal
genetic information, they're not whole cells or foreign bodies.
Right. Okay, and so in the cell-free DNA screening typically looks for trisomies 18, 13, 21, and then the sex chromosomes, correct? And trisomy 21 is Down syndrome. Trisomy 18 is it's the Patel, right?
Or am I mixing up? I always get those mixed up.
So yeah, so trisomy 18 is Edwards, trisomy 13 is Patel. This has been a struggle with me for 20 years. I always get those two mixed up. Okay, and that's the other thing is I always think about numbers rather than the actual name. So that's another reason why. Okay, so when can this test be done?
I would say most of the time we don't actually use Edwards and Patel so much anymore. It's 13.
Yeah. Okay, so when in pregnancy can the cell-free
DNA screening be done? So there are some labs that say it can be done as early as 9 or 10 weeks in pregnancy. We as an institution recommend doing it after 11 weeks in pregnancy, just because you need that time for that DNA from the pregnancy to build up in your blood for us to actually get a reportable result. The earlier in pregnancy you do it, and early on in the semester, the less likely you're going to have an informative result. And there's a lot of things like the weight of the patient, influencing the blood volume that someone has, if people are on blood thinners for whatever reason, things that would just limit the amount of DNA per sample, that we just generally get the most success after 11 weeks in pregnancy doing this. But it can be done anytime after 11 weeks in pregnancy.
Yeah, and I know a lot of institutions will do 10 weeks, but I do think that we see a lot more no-call results, and we'll talk about that earlier on, that we do it. I do not agree with it being done before 10 weeks, and I know a lot of providers will do that. I think the potential of having a no-call result is too much, and could cause too much stress, that I would never offer it before 10 weeks. 10 weeks is the earliest I would offer it, but I do know that
we don't offer it any earlier than that.
What's that? Yeah. Okay. How accurate is the cell-free DNA screening
will
test?
Always depend on what your chance was before the test to have that pregnancy affected. I think people incorrectly, and physicians as well, conflate detection rates with accuracy. Those are not the same thing. Nobody from this test should ever be telling you you have a 99% chance to have a child affected without telling you that they did some math to get to that number first. So detection rates of how many pregnancies this can detect that would be affected with the condition, usually for Down syndrome, are around 99%. So that's sometimes where they get that number from. So if there's 100 pregnancies affected with Down syndrome, about 99 of them would flag positive on this type of screening. For trisomy 18, usually metadata tells us it's about 97% or 98%. For trisomy 13, it's a little more wishy-washy, but can be up to 99% as well. And so when we find that there is a positive result, we do some math to calculate what we call the positive predictive value. And this is the actual chance baby's affected with that condition. And that's always going to depend on what your chance was before the test to begin with. And that's where someone's age-related risk can be a factor of what the chance was based on age. If there are ultrasound findings, which we'll talk about here in a little bit, or any other prior screening tests that maybe weren't quite as high of a detection rate as with NIPT. So we always start with that number first and calculate how sensitive the test is for that. And that's where we get a number. So most people over the age of 35 are probably getting an accuracy or positive predictive value for baby to actually be affected in the realm of about 80 to 90% for Down syndrome. That number is a lot lower for conditions like trisomies 18 or 13 because there's a higher chance of what we call confined placental mosaicism, or differences just in the placenta that aren't necessarily in the fetus. And so those chances that baby's affected are going to be lower at 50, 40, 30%, depending on what the chance was to begin with before.
Okay. Now, we've already talked about what traditionally the cell-free DNA screening is looking for: trisomies 21, 18, 13, sex chromosomes. But there's other things that the test is starting to look for, but it's not really being offered at all places because it's not been validated or has not been shown to consistently perform. Those things would be like what I came up with was triploidy, microdeletions, large deletions. So when would we potentially use, or can we use cell-free DNA to detect other things besides those trisomies?
I think those can be helpful in cases where you have a pretty strong clinical suspicion for some of those. So there's findings on ultrasound that make you think of some of those conditions. Triploidy is a condition where there's 3 copies of every single chromosome. Most of the time, that's one egg that's been fertilized by 2 sperm. And that's also something that can happen. It can be a pretty common cause of early first trimester miscarriages, but occasionally it can go through the first trimester and well into the second trimester, and usually presents as really tiny, tiny fetuses or underdeveloped fetuses, really abnormal placentas. And so if a patient really isn't feeling like a diagnostic test is something that they'd want to go through, sometimes they can consider screening through NIPT for triploidy. However, you need a very specific form of NIPT to be able to do that. There are 2 different platforms or types of NIPT. There's one through NGS, which is just sequencing, and there's one that uses SNPs, or single nucleotide polymorphisms, to see how much of that information is there. And only a SNP-based platform can detect triploidy. Those other things you mentioned, those are called microdeletion syndromes. And so those are smaller pieces missing in the chromosome that aren't whole missing chromosomes, but maybe have then just a smaller chunk that wasn't included. And those can be pretty hit or miss because they can be pretty variable from person to person. That being said, that means sometimes they can be inherited from an affected parent. And so if the pregnant patient themselves has a microdeletion syndrome, that part of the test is null and void to be able to determine fetus would be affected with that.
Mm-hmm.
Same with sex chromosome differences. If a parent themselves has a sex chromosome difference, you are not going to be able to tell if that fetus has a sex chromosome difference.
Right. Okay. So what it's being used for and what it's most accurate and is performing the best for are for trisomies 21, 18, and 13 and the sex chromosomes. There's another indication to do it. Again, not all places will offer that for the things that we just mentioned, like triploidy, microdeletions, large deletions. But I would think that if that is suspected based on fetal ultrasound findings or there's a history of it, the best way to rule that in or out would be with the diagnostic test like a CVS or an amniocentesis. That's the best way to know for sure, because these screening tests we have just don't perform as well for those yet. Hopefully sometime down the road they will. But I know we typically, if we're suspicious of those things that aren't the typical trisomies, we will recommend diagnostic testing. Does that sound about right? Yeah. Okay. Now let's talk about the fetal fraction for cell-free DNA, because everybody talks about that. What does it mean, the fetal fraction, and what can affect?
So that's the amount
fraction
of DNA that they estimate is coming from the pregnancy itself and not necessarily from the pregnant patient. And there are lots of things that can impact it. Earlier in gestation, sometimes pregnancies don't just put out as much DNA and there's no real reason for it. If the placenta isn't developing as well as we would expect and there are placental problems, then that can certainly impact it. One of the biggest impacts that we have is weight of the pregnant person, because as our weight increases, our blood volume has to increase to accommodate for that extra space. And so the more of a blood volume you have, the more dilute your genetic information going to be in each draw you take from that. And so that can certainly be a contributing factor. If you're on blood thinners, the same concept applies, where you're going to have a more dilute sample of that DNA per blood test.
Okay, so then what the fetal fraction we want
usually anything about 4% we can pretty reliably do NIPT on. There are some labs that say that can do it anywhere above 2 to 3%, but that's not going to be consistent across all laboratories.
Right. Okay. So what does it mean if someone gets the NIPT or cell-free DNA screening test and it comes back as a no-call result? Or this is something about low
so that
fetal
just
fraction.
means there
what
was not enough of the DNA that they attribute from the pregnancy to be able to accurately measure what's a typical result versus an atypical result.
And the things that you just mentioned can cause a no-call result to occur. But so what do we do in that situation if a patient had the cell-free DNA screening test and it came back as a low fetal fraction, or it can come back as either low fetal fraction or a no call?
So it depends
right?
on the laboratory. Usually they'll make a note on there as to why there was a no call. The vast majority of time it's because of low fetal fraction. Other times it could be quality control issues with the sample that has nothing to do with the fetal fraction. But if you have a low fetal fraction result, then we would talk about kind of possibilities for explanations of why it may be a low risk result. Certainly, if there doesn't seem to be any other explanation for why that's the case, more severe chromosome differences like a trisomy 18 or 13 or even a triploidy, things that can also impact the placenta and how well it functions, may be the cause of some of that. And so it's a discussion of, do we try that NIPT one more time now that you're a little further along than the first time to see if we can get an informative result? Or do we want to pursue an option of a diagnostic test depending on how far along you are?
Mm-hmm. Right. So what I've seen a few times, because we get a lot of referrals from outside providers, is they'll keep drawing it and keep drawing it. And the next thing you know, they've had it 3 times, 4 times. And my opinion, and you can give your opinion, if we can't really find a reason, I would do it one more time, maybe wait a week or 2, unless there's something else going on with the pregnancy that we see on ultrasound that is indicating that there could be an aneuploidy or a chromosomal difference. And you may not want to wait that extra how many ever days it takes to get an NIPT and discuss, just go ahead and getting a diagnostic test. So that obviously would depend on when you're getting those results. But I wouldn't keep doing it over and over again in the hopes that you're going to get a result. But overall, most of the time when they do a second test, you can get a result up into, I think it's like 75%
depends
of cases.
on why in the first place.
Right.
also cap it at 2 times. We don't offer it any more than just one other reason.
Right. Yeah, unfortunately, I've seen that a lot more from some of the outlying providers that are doing it multiple times, and what all that it does is delay getting a more accurate diagnosis. So yeah, I think repeating it one time would be okay, unless I see something on ultrasound where I think that it might be best to not delay and go ahead and offer talk about doing the diagnostic testing like a CVS or amniocentesis. Okay. Why is it important to have accurate pregnancy dating? And, so let's talk about pregnancy dating. There's been studies that have shown that up to 3/4 of pregnancy of patients, even when they're 100% sure at the first day of their last menstrual period, they are not correct. I change due dates with these early ultrasounds more than I don't, actually. So, and it's not any disrespect to the individual. It's hard. I mean, we don't always think about it, and we might have written it down or skipped a month or, didn't, recall, or it might have been a shorter period and we didn't really realize. So having early pregnancy dating by ultrasound is ideal for everyone to get accurate dating. So why is it important, if we can, to have that accurate dating, preferably by ultrasound, before we do the cell-free DNA
because it helps
test?
make sure doing it in the right time frame to be able to do this test. And contrary to popular belief, biology is not 100% foolproof. And so even if you know your LMP to the date, your body may not have implanted that embryo on the date that it would have expected to. You may not have gotten pregnant, have had a different ovulation window than you've expected to. Our bodies do weird things to us. So it's always helpful to have an early first trimester ultrasound before considering your screening or diagnostic testing options, just to make sure that we know what those options are and what those windows may look like.
Yeah, I love having first trimester dating. It's so important. And we're doing it a lot more now than we used to, because we're getting more information and we understand the value of it. So it's important that we go ahead, even if the patient says they know their LMP 100% sure. So what if it's twins and you didn't know and you got the cell-free DNA screening test, and and then you find out later. So that does affect things. So it's important to try to have that sonographic dating confirmation before we do this test. Are there any situations when we should not offer cell-free DNA screening to women?
If the patient themselves is affected with a condition that you're concerned for on the NIPT, if there are definitive concerns for a specific condition that would not be included on NIPT, not all insurances are covering NIPT for everybody. I know we're a little bit behind the times here with one of our major payers in Pittsburgh. So it's only covering NIPT for someone at an increased risk. So over the age of 35, there's an abnormal ultrasound finding. One of your prior screens, which we'll talk about here in a second, was high risk. So there are a couple instances where it may not be the best test for you, but it's important to have that conversation with the provider to explain why that may be the case and what alternatives there may be.
Right. And then the other thing before we move on to the next type of screening, two things. Number one, if you do have the NIPT or cell-free DNA screening test, you do need to get the alpha-fetoprotein measurement after 15 weeks. Why? Because elevated AFP could potentially indicate that there is like a neural tube defect, and subtly potentially a placental issue. So getting that after 15 weeks is still required. And also, if you are advanced maternal age and you do the cell-free DNA screening test, more and more of us are offering the NT screening, the nuchal translucency screening, along with that, because of the increased risk of having defects in the fetus, like birth defects in the fetus in that age group as well. So if over age 35 and you're getting the cell-free DNA screening test, talk to your provider about getting just that NT measurement, not the whole thing, not the blood test plus the NT. You don't need to repeat, double dip in the blood test screening. You just get that NT measurement if over age 35, and especially over age 40. So that's important to know about the cell-free DNA screening test.
There have been a couple of people asking about PGTA and using NIPT after that. We do not have all the time in the world to talk about PGTA, but I do counsel on it regularly. PGTA is also a screening test to figure out if embryos are going to be more or less likely to be affected with chromosome differences. It still takes from that trophectoderm, that area that's going to become the placenta for the pregnancy. So actually following that up with NIPT doesn't really add any additional information. information because it's still just getting placental information. It doesn't hurt if you want to do it, but the only way you're going to find out more specific information about whether that really is a low risk PGTA result from a successful implantation is through ultrasounds as well as amniocentesis after 16 weeks in pregnancy. Certainly we can go through a whole other live about PGTA and IVF screenings, but generally not recommended.
Yeah, so it's still, so we still, the ASRM and ACOG and all them still recommend that we offer antenatal screening to those with PGTA tested embryos.
But it's a conversation of what kind of antenatal screening is actually information you have.
Right. Right. So you got to discuss which type of antenatal screening is best depending on your specific situation. But I do know a lot of patients who understand that and will opt for especially the older age group, will opt for the diagnostic testing